Sorry, Cap. Sorry, Cap, everyone. Sorry, Cap. Sorry, Cap. How's everybody doing? So we haven't done an English video for a while, so I figured today we're gonna do a video in the English language. ไม่ได้ทำวิดีโอเป็นภาษาอังกฤษมานานนะครับเลยวันนี้เลยตัดสินใจพยายามจะทำวิดีโอภาษาอังกฤษสักแป๊บหนึ่ง and so when I do a video in English it's usually a tutoring video, so yeah, so we're gonna do some math tutor. And as I said, studying medicine or medical science is very easy to learn. It's not difficult. And many people think that medical education is difficult. It's not. And when I was a student, when I was in medical school, I used to hide behind my friends, like in anatomy lab. I used to stand behind somebody so my professor don't pick on me. And I find out that if you hide behind somebody, if you don't want to be picked on, your professor's going to pick on you more. And my professor would say to me all the time, Chuck, what is this structure? Explain the function of this structure. Explain the function of this nerve. Explain the function of, muscular cutaneous nerve more and more. So I learned, like in medical school, don't hide yourself. Your professor's going to pick on you more and more. And this professor was very cool. He actually pulled me aside and he said, Chuck, and he calls me Chuck. Chuck is short for Chakriwat. Chakriwat, my name is very long, so in medical school they call me Chuck. And he says, Chuck, medical education is not difficult. It takes very little brain. You don't have to be smart. You don't have to be a genius to study medicine. You don't have to be a genius to be a doctor. What you need to do is you need to have good studying skills. You need to have discipline in your study. You need to be able to sit there long hours and go over the concept again and again and again. And that's how you work your concept into your long-term memory. Just to repeat again and again and again, and also to do your cue banks. When you do your cue bank, when you practice your question, that's how you practice to apply the new knowledge that you've learned. Because knowledge is nothing, right? Knowledge is nothing if you cannot apply it. If you don't know how to use your knowledge, if you don't know how to apply the knowledge that you've acquired, then that's nothing. Then that knowledge is not going to be useful for you if you don't know how to apply it. So to practice the application of knowledge is to do your cue bank, right? And this is where I'm trying to do my project of having our own cue bank, of having our own cue bank for students to practice, right? And these questions that we're doing today, I got them from Kaplan Q Bank, USME Kaplan. But as I said, my dream is to have our own Q Bank, to have CMAC Q Bank for students to practice since their first day of medical school all the way to their residency. So this is my dream. I'm working on this with a few other doctors and a few other partners to have CMAC Q Bank. And as I said, usually in USMLE, the questions will come in vignette form. The question will come in story form, right? Because this is in the real world. No patient's going to come to you without a story. Every patient has a story, No patient's going to come to you and say, oh, I have a headache. And, what's the treatment or whatever. Because like headache can be from so many things, right? For example, maybe you're going to see in a question that somebody goes swimming in a lake and then they come to the doctor with a headache and with a temperature and also maybe in the questions then you're going to see that the patient has tachycardia, the heart beating so fast, low blood pressure, temperature. That's the sign of infection, and the patient been swimming. Maybe the patient caught some kind of bacteria in the water or something like that. Also, you can also in the questions that maybe you'll see that the patient has some kind of hepatitis or liver disease. So that's going to tell you that when you treat the patient with pain or temperature, to avoid medicine like acetaminophen or paracetamol, because those medicine will cause the patient to have liver failure more, because these medication leaves the system via the liver. So you want to avoid those medicine. You want to avoid acetaminophen, and you want to avoid paracetamol. So you want to treat this patient with like maybe ibuprofen or something. So this is an example of the question stem telling you everything. You need to read the question stem of these questions, because every word of the question stem is meaningful. And with that, let's do our first question. I think today we'll do some psych question, and also in the USMLE, that's 3-step, right? Step 1, step 2, step 3. And step 1 is probably the one of the most difficult exam. And step 1 is more diagnosis, you want to diagnose the patient. And also in step 1, that's little like miscellaneous question of like asking about the enzyme, the missing enzyme, and things like that. So step 1 is more difficult. Step 2, step 3 is more about diagnosing the patient. It's more about like, you already know the diagnosis. So what's the next step of treatment? And usually, step 2 and step 3 is quite simple, because you're doing rotations, or you're doing your residency, so you're seeing cases every day. And I think in my step 3, I didn't even take time off to study, so I just went and took it. I think I took like 1 weekend to like go over everything, and then step 3 is a 2-day test. So it was very, very easy for me, because I was seeing patients every day when I took my step 3. Okay, with that, let's do a question. First question that we're gonna do is gonna be psych question, psychiatry question. We haven't done psych that often, so we can do psych. Okay. 65-year-old man was brought to the office by his daughter after she became concerned about him. He has been hopeless and helpless since his wife died 3 months ago. His daughter is worried about his isolated behavior and lack of appetite. He has lost over 30 pounds. He does not seem interested in getting better and believes he should have died with his wife. What is the most likely diagnosis? So it's diagnostic questions, more like step 1 question, right? And it's a psych question. Basically, as we've said, this man, he has lost his wife, and it seems that he's grieving, and also, there's some concern as well that he's lost a lot of weight. He feels hopelessness, and things like that. Let me read the question up for you again. 65-year-old man was brought to the office by his daughter after she became concerned about him. He has been hopeless and helpless since his wife died 3 months ago. So his wife died 3 months ago. His daughter is worried about his isolated behavior and lack of appetite. He has lost over 30 pounds. He does not seem interested in getting better and believe he should have died with his wife. What is the most likely diagnosis? A. Bereavement. Bereavement is basically grief. B. Dysthymia. C. Major depression. D. Adjustment disorder. And E. Bipolar disorder. What's the answer? And when you're doing these questions, the most important thing is to highlight. And when you highlight, the questions, when you get lost in these questions, you look at what you highlighted, that's going to steer you back on track. That's going to steer you back on track, and you're going to be able to think of the differential diagnosis reading your highlight. And what I like to highlight is I highlight the patient's age, and I highlight the patient's sex, and I highlight the positive symptoms that I see, and that way I'm not going to get lost. Age is very important. Age of the patient is very important because because you can rule out so many things with age. Like the sample I like to give with age is that, and sex is that, so many things you can rule out with age. Like, you see a girl, a young girl, 20-year-old girl with a breast mass, that's more likely that she's having like fibrocystic mass changes of the breast instead of cancer, because 20-year-old is too young to have cancer. And so that's why highlighting the age and sex is very important. And with this question, what I'm going to highlight, I'm going to show you. So 65-year-old man, brought my daughter after she became concerned about him. He has been hopeless and helpless since his wife died 3 months ago. So his wife died 3 months ago. His daughter's worried about his isolated behavior and lack of appetite. He's lost over 30 pounds and he doesn't seem interested in getting better. And he believed that he should have died with his wife, right? What is the most diagnosis? What is the most likely diagnosis? Okay, so this is the question. So what do you guys think? I think from reading this, and the choice, as I said, bereavement, a dysthymia, major depression, adjustment disorder, or bipolar. And this is, as looking at this, is between, I think, is between grief, bereavement, or a major depressive disorder. And this patient, grief or bereavement seems like the right answer because he's lost his wife, and of course bereavement, you see symptoms. It's to diagnose somebody with bereavement, you have a feeling of grief, you have a feeling of loss. That's normal. And the symptoms could last up to like 6 months. It could be longer than 6 months. And what you see in bereavement, what you see in grief, is you see sadness, you see patient worrying about the disease, patient worrying about their loved one. I hope they're in a better place now, they're not suffering anymore, and things like that. And they feel irritable, they have sleep disorders, maybe sleep difficulty, they don't fall asleep easily, they have poor concentration, that they're more tearfulness, and typically, I said, these symptoms may last, up to 6 weeks, maybe longer. And supportive care from family members and from loved ones will help with grief. And so you have to surround yourself with family, right? And surround yourself with friends. And also, you want to talk more about, the loved one that you've lost. One thing that helps people cope with loss is what we call a letter of tribute. Letter of tribute is what you write. You write in a piece of paper all the positive quality of the person that you've lost. How they've helped you, how they've been caring, and just positive tributes of the people that you love, of the person that you love that you've lost. You take a drive into another city, and then you mail that letter back to yourself, right? So when you get home a few days later after your trip, you open up your mail, and then you see a letter that you wrote about this person, all the positive qualities, how caring they were, how they helped you, and that the words of of advice that you cherish, and then you see all these positive qualities of the person, and that helps you cope with grief. That helps remind you of of how this person has made a positive contribution to you and society and your loved one. So that's called a letter of tribute, and it helps with grief a lot, right? If you don't cope with grief well, the patient could fall into major depression, right? And major depression has similar symptoms, but also the patient would feel like that they're hopeless, they are worthless, and also the patient would feel that they don't want to live anymore, they want to commit suicide, right? So that's one of the major point of major depression. It's like feeling hopeless, feeling worthless, and feeling suicidal. And when you see a patient who is depressed, the most important thing that a doctor can ask the patient, if you have one question to ask that patient who's depressed, the question that you need to ask is, do you feel like hurting yourself? Do you feel like hurting yourself? The most important question that you can ask a patient who feels depressed, because we want to make sure the patient feels safe. We want to make sure the patient, don't hurt themselves. So if you have one question to ask a patient who's depressed, the question to ask them is, do you feel like hurting yourself? Because, as I said, patient safety is number one priority, right? So that's that. And major depression, as I said, patient to diagnose major depression is, the patient have to have a different mindset or different symptoms to their normal behavior for 2 weeks, right? For 2 weeks, the patient have to have they have to feel that they don't enjoy their normal activity anymore, and they have to have changes in their sleep, either sleeping more or sleeping less. Normally, patient who is depressed, they don't sleep well at night. They don't sleep very much, right? And atypical depression patient will sleep a lot. They'll sleep all day. So, and also appetite. They have they have loss of appetite, and also they have weight decrease. That's typical depression. Atypical depression patient would they would eat more, they'll eat all the time, and they'll gain weight. So we can put that as sleep changes and appetite changes, right? And they have poor concentration. Another thing about patient depression depression is that we see something we call psychomotor retardation. Psychomotor retardation is basically slowness in thinking, or their cognition slow down, so their thinking slow down, and their physical slow down, their movement, everything slow down. So movement and thinking slow down, and of course they're gonna feel worthless. They're gonna feel that they want to kill themselves, or they don't want to live anymore. So with this question, it's true that this 65-year-old man, his wife just died, and he's having normal grieving, right? But then he also feel that he should have died with his wife. That's suicidal ideation, and he feels worthless. He feels lack of appetite. He feels hopeless, right? So what's happening here with this gentleman is that his wife died. He was grieving, but then also he fell into major depression, right? So the correct answer here is major depression, because he has suicidal ideation. He wants to die with his wife, and that's not normal grief, right? So the answer here is major depression. Other choice we have dysthymia, adjustment order, and bipolar. That's not the answer. Because dysthymia, what is dysthymia? Dysthymia is like chronic depression. So the patient have to have, but the symptoms of dysthymia is a little bit milder than major depression. So dysthymia is the patient feels depressed almost every day. They feel sadness almost every day, and they have to feel like this for at least 2 years. That's the criteria for diagnosis. Is the patient feels sad every day for almost 2 years, right? Adjustment disorder is like, patient have some kind of social changes, like change of school, loss of job, loss of income, that that would cause them, a lot of anxiety, a lot of depression. So that's adjustment disorder. Actually, bereavement of grief falls under the umbrella of adjustment disorder as well. Bipolar is that you have, a cycle of manic behavior and also depressive behavior. You don't see that in the question stems. It's not the answer. And of course, manic episode is when you feel like, you have precious speech, you feel like you don't need sleep, you feel like you suddenly become like goal-oriented behavior, you feel like, a heighten of your emotion, behavior, concentration, and heighten of, pleasure-seeking activity, a lot of energy. And then also, after that, you feel like you go through a bout of depression. So bipolar, two poles of your personality, that's bipolar, and you don't see that, right? So the answer here is what? The answer here is major depressive disorder. And also this question wants to know if you can distinguish between grief and major depression. And wording is very important. For psychiatric question, timeline is important. Like, to diagnose someone with depression, you need to see all those symptoms for like 2 weeks. And you need to know here as well that bereavement of grief is at least 6 months. Patient feels sadness, patient will be teary, patient will be worrying about the deceased for at least 6 months. And if they worry more than 6 months with symptom of worthlessness, symptoms of saying that they want to die with their loved one or something like that, then the patient is falling into major depression, right? Yeah, so that's a side question. Let's do another one. My voice is kind of giving out, so just bear with me. All right, another question. Let's do a simple one. 67-year-old man with history of hypertension and diabetes comes to the emergency department with sudden onset of weakness in the right arm, right leg over the last hour. On exam, he could not lift the bottom of his right side of the face. What is the best initial step? A. CT without contrast. B. CT with contrast. C. Give aspirin. D. Give thrombolytic. And E. MRI scan. So this question is more of a step 2 question, right? This question is like, you kind of like have an idea of the patient that they either have a stroke or they either have a transient ischemic attack. And then, you are asked the next step of management. So that's like a step 2 or step 3 question. So let me show you how to highlight. So 67-year-old man, and then the history of hypertension, diabetes. That's important too, because hypertension and diabetes, those two things contribute to stroke, right? Those two things contribute to stroke or transient ischemic attack, because hypertension will cause damage to your blood vessel, and when it's damage to the blood vessel, that's more prone to atherosclerosis, or that's more prone to having a thrombus. And when you have a thrombus, like that, the patient's more prone to having ischemic attack, because the thrombus will break off and then will cause will interrupt the blood supply to some certain part of your brain, right? And diabetes is the same. Diabetes, patient will have more plaque. Patient will have more plaque in the arteries, and that will cause some kind of blood supply interruption to the brain also. So the patient comes to the emergency department, sudden onset of weakness on the right side of the arm and right side of the leg. So that's important finding. On physical exam, the patient cannot lift the bottom half of the face on the right. So that's actually telling you the difference between Bell palsy and stroke, right? So the patient's having either stroke or transient ischemic attack. What is the best initial step? So the best initial step, right? So this is what I would highlight. So when the patient comes in with transient ischemic attack or stroke, what's the first thing that you have to do? The first thing that you have to do before any therapy is that is to distinguish what type of stroke the patient have. So either a ischemic stroke or a hemorrhagic stroke, right? Because the treatment is different, like within the first 3 hours, if the patient have a stroke, you can give them a thrombolytic. Thrombolytics like to break up the blood clot, right? But what if the patient has hemorrhagic stroke and you give that thrombolytic, the patient's going to be worse, the bleeding's going to be worse, right? So this is why you have to establish what kind of stroke the patient have. Ischemic stroke is like some kind of broad thrombus, maybe from a heart valve break off, and goes to your carotid, goes to your brain and block that blood supply to the brain. That's ischemic stroke. A hemorrhagic stroke is that maybe you have some kind of like an aneurysm in your brain, and then the blood pressure gets stronger, the aneurysm gets bigger in your brain, and then pop, the blood vessel in the brain breaks, and there's active bleeding in the brain. That's hemorrhagic stroke. So if the patient has active bleeding in the brain, you cannot give thrombolytic, you cannot give a blood thinner. If you give those, then the bleeding in the brain would be more and more. The patient will suffer more. The patient may die from all that bleeding. So the first thing that you're gonna do is that you have to do an MRI or something. Or not MRI. You have to do like some kind of imaging study, a quick imaging study, to see if the patient has ischemic stroke, which is like some kind of clot in the brain, or a hemorrhagic stroke, which is some kind of like like blood vessel breaking, and the patient has like active bleeding in the brain, because that's gonna like dictate what kind of like treatment the patient will have, right? Is it to give like more thrombolytic? Is it to give some kind of blood thinner? So the question here is that the patient has some kind of like transient ischemic attack or a stroke. What are you going to do next? Like, what's the first thing you're going to do? And also you're going to do an imaging study, right? What would you do? Would you do CT of the brain without contrast? Would you do CT of the brain with contrast? Or would you do an MRI scan? And CT is very fast. So you would do CT scan, right? But would you do a CT scan with contrast or without contrast? You don't need contrast to be able to see blood in the brain. So you would just go ahead and do a CT scan of the brain without contrast. You can see a lot of blood with that. Contrast, you use to see soft tissue, so you would do CT scan of the brain with contrast. You want to see like some kind of soft tissue, like a tumor, or maybe if you want to see some kind of infection like abscess or something, you can do CT scan with contrast. But if a patient comes with a stroke, you can do a quick CT scan without contrast, because like you don't need contrast to see blood in the brain. Also, you don't want to subject patient to unnecessary things like contrast. You don't want to do unnecessary things to patient if they don't need it. And also, why would you spend more money on contrast, right, when you don't need it? So when the patient comes in, you just do a quick CT scan of the brain without contrast. And so the answer to this question is B, CT scan without contrast. And thrombolytic is that you can give thrombolytic to the patient. If you diagnose the patient as having ischemic stroke, so that's they have like a blood clot in one of the blood vessels in the brain that's contributing to stroke. But again, thrombolytic has a timeline. If the patient diagnosed of stroke within the first 3 hours, then you can give a thrombolytic, and aspirin's a blood thinner, and maybe after that, the patient should be on aspirin after they recover a little bit, right? MRI scan takes a little bit more time, so you don't want to do MRI scan, okay? And of course, you can tell if the patient has a stroke or transischemic attack. You can kind of like see what part of the brain or what blood vessels kind of affected by the symptoms they're having. Let's say the patient can't move their arm or their leg. That's like the motor cortex. So that would be maybe kind of like a stroke or ischemic stroke of like the anterior cerebral artery. The anterior cerebral artery kind of supplies the motor cortex, the cortex of the brain. That's your arm, your leg. That's like the movement area. And if the patient has trouble speaking or understanding language, maybe that would be like the Broca's area or something like that. So it'll be like the frontal cortex area of the brain. So that would be like the maybe the middle cerebral artery or something like that. So these are the things that will give you clues of which part of the brain is lacking the blood supply. And so I think this is all I have today. And I'm sorry again, my voice is giving out. I've been having like very, very, very dry voice lately. And but I still want to do a live one, come say hello to all of you. And so we've been talking English today. Maybe the next time we can talk in Thai. And hope all of you are doing well. And just want to say hi again. Take care of yourself. Sawasdee krap.